When a part of your body suddenly changes shape, or worse, just seems to disappear entirely, your first instinct is usually absolute panic.
Oh, absolutely. Total panic.
Right, because you look in the mirror and you expect the exact same reflection today as you saw yesterday. But today, we're looking at this diagnostic landscape where the physical structure of your body literally gets rewritten.
Yeah, it's a profound shift.
It is. And welcome to this deep dive, by the way. Today's topic is incredibly intimate, but, it is so deeply important because it's usually just shrouded in total silence.
It really is.
So we brought a stack of medical literature today to answer one very specific, crucial question. We've got clinical updates from the Royal College of Physicians of Ireland, management guidelines from the British Association of Dermatologists, position statements from the British Society for the Study of Vulval Disease, and several peer-reviewed articles from the Journal of Sexual Medicine.
That is a very comprehensive stack of sources.
Yeah, we really wanted to cover all the bases because our mission today is to figure out, can a skin condition called lichen sclerosus actually cause the burying or encapsulation of the clitoral glands?
Right.
And I'll just give you the short answer right away. It is a resounding yes. But the real aha moment, the thing we found in the sources that changes everything, is that even when the clitoris appears to have just vanished due to severe scarring, it is almost always completely intact underneath.
Which is huge.
Yeah, and it can actually be uncovered.
And that realization, that is a profound paradigm shift for patients. We're talking about a condition that fundamentally alters a person's anatomy. And, often while they suffer completely under the radar.
Right, because nobody talks about it.
Exactly. So to understand how this highly innervated, really complex piece of human anatomy can essentially get swallowed up by the body, we kind of have to look at the mechanics of lichen sclerosus, or LS.
Okay, so lay the foundation for us. What exactly is LS?
Basically, it's a chronic autoimmune inflammatory skin condition. It primarily affects the anogenital region, so specifically the vulva and the perianal area in women.
Okay.
The immune system essentially gets confused. It becomes overactive and inappropriately targets this specific skin. So the tissue becomes incredibly fragile. It takes on this crinkled, almost like cigarette paper appearance.
Oh, wow. Cigarette paper.
Yeah, that's the clinical description often used. It develops these distinct porcelain white plaques. And, crucially, it causes intense, debilitating itching, along with very painful tearing.
See, and that brings up something our sources are incredibly adamant about clearing up right out of the gate.
Right, the misconceptions.
Yes, because of where it's located and, because of the severe itching, people immediately jump to the conclusion that it's a sexually transmitted infection, or maybe a persistent yeast infection, or somehow related to poor hygiene.
Which really couldn't be further from the truth.
Right.
It is absolutely not contagious. You cannot pass it to a partner. And, frankly, no amount of washing will prevent it. In fact, overwashing with harsh soaps can actually aggravate it.
Make it worse. Yeah.
It's entirely an internal immune malfunction.
Well, and the demographics in our sources paint this really complex picture of who is actually dealing with this malfunction. There's a bimodal distribution.
Right.
Which means it peaks in two very distinct life stages, right? Prepubertal girls and then postmenopausal women. And the mean age of diagnosis for adult women sits around 52 to 60 years old.
That's correct, yeah.
But the prevalence numbers, the actual rate of how many people have this, that is what really caught my attention.
The massive gap in the estimates.
Yes. Some estimates say it affects 1 in 1,000 women, but then other sources suggest it could be as common as 1 in 80. I mean, a gap that massive tells me we are missing a huge part of the puzzle.
We are. We're missing a massive portion of the patient population, and it's mostly because of a culture of silence. Chronic underdiagnosis is basically the defining feature of LS. Many patients are profoundly embarrassed to report vulvar symptoms to anyone.
Because it's such a taboo topic.
Exactly. A postmenopausal woman might mistake the intense itching and the tissue changes for vaginal atrophy, or she might just assume that discomfort is a standard, unavoidable part of aging.
Like, oh, my body's just getting older. This is what happens.
Right. So they don't bring it up to their physicians. And conversely, when they do finally bring it up, a lot of general practitioners just aren't trained to recognize those early signs of LS.
Wow. So they just miss it entirely.
They do. They'll prescribe a standard antifungal cream, the symptoms persist, and the patient simply, well, they just give up. They learn to live with the pain.
And living with it allows the disease to just quietly progress into something the Royal College of Physicians of Ireland calls architectural distortion.
Yes.
That phrase, I mean, that stopped me in my tracks. Architectural distortion. The literature describes the skin essentially melting and fusing together.
It's a very aggressive structural change.
Right. They say the labia minora, the inner lips, can completely resorb. They just flatten out into what the texts describe as a plastic doll appearance, where the normal, distinct anatomical features are permanently lost.
The visual of that is striking. And
Yeah.
you have to imagine the psychological toll of watching your own body erase its defining features. It's immense.
I didn't imagine.
This chronic inflammation basically destroys the natural elasticity and the healthy separation of the tissues.
Okay, so I'm trying to visualize how this happens on a cellular level, because to me, it sounds like a house being remodeled by rogue contractors, right?
Yeah, it's a good way to look at it.
But instead of knocking down walls or ceiling doors, imagine they are pumping rigid concrete directly into the flexible foundation of the house. So the whole structure is losing its ability to bend and move, and everything is just setting into the solid block.
I love that analogy because that concrete idea captures the histology perfectly.
Really?
Yeah. When we look at LS tissue under a microscope, we see what's called a band-like inflammatory infiltrate in the dermis, so the deeper layer of the skin.
Okay.
White blood cells essentially flood this lower level, and they release inflammatory cytokines. So in response to this constant immune attack, the fibroblasts.
Wait, fibroblasts? Those are the cells that build the skin, right?
Exactly, the builders. They start overproducing collagen to try and repair the area. But it's not healthy, flexible collagen.
Because the environment is basically under attack.
Right. The collagen becomes homogenized, it thickens and turns into this dense, rigid sheet of scar tissue from the inside out.
So the foundation really is turning to concrete.
Yes, literally setting like concrete.
Wow. Which, I mean, that leads us directly to the most intricate structure sitting on that foundation, the clitoris. If the surrounding tissue is becoming this rigid, fused sheet, how does this process physically bury the clitoral glands?
Well, the literature calls it clitoral phimosis or sometimes clitoral fusion. And the mechanics of this fusion come down to how the anatomy is naturally supposed to interact. The visible part of the clitoris, the glans, sits at the top of the vulva. And it's normally protected by a fold of skin called the clitoral hood, or the prepuce.
Right, like a little protective sleeve.
Exactly. And in a healthy state, this hood is highly mobile. It retracts easily to expose the glands during arousal, or just for regular hygiene. But as those rogue contractors pump concrete into the foundation, that mobility just vanishes.
It stiffens up.
Yes. The inflammation causes the inner lining of the clitoral hood to stick directly to the glans itself.
Wait, so the hood essentially glues itself down to the very thing it's supposed to just lightly cover.
Progressively, yes. The edges of the hood actually fuse together, sealing the glands underneath a thick layer of that rigid, porcelain white scar tissue we talked about.
Oh my gosh.
Yeah, eventually the clitoris becomes entirely encapsulated. To the naked eye, it appears as though it is completely dissolved or vanished.
And this is where that incredible reassurance from the British Society for the Study of Vulval Disease really comes into play.
Right, they're good practice guidelines.
Yes, because they state unequivocally that even when the glans is completely invisible, the clitoris itself has not been destroyed. It hasn't dissolved. The nerve-dense glans is still perfectly intact beneath the surface.
It's all still there.
The architecture of the space has been sealed shut, but the room itself is still entirely there.
Finding that out, I mean, that is often an incredibly emotional moment for patients. People who have spent years believing they permanently lost a part of their anatomy. The glans is just trapped. It's not gone.
But, just because it's there doesn't mean it functions the same way.
No, not at all.
I mean, think about putting on a pair of really heavy, thick winter gloves, right? If you run your hand over a textured surface with those gloves on, you can sense deep pressure. Like your hand is touching a table.
Right, you feel the weight of it.
But the sharp, intense, detailed sensation is completely muted by that thick barrier. So if the clitoris is buried beneath rigid scar tissue, does this fusion numb the person entirely, or does it just change the appearance?
It acts exactly like that heavy winter glove.
Okay.
The glans clitoris contains an immense concentration of nerve endings that are specifically designed for fine, sensitive touch, which is obviously required for sexual arousal and climax.
Right.
By placing a thick, inflexible layer of homogenized collagen right over it, you create a formidable physical barrier to those nerves. So patients frequently report that they can feel deep pressure, but the acute sensitivity is just blocked.
Which would predictably disrupt the entire sexual response cycle.
It absolutely does. It leads to secondary anorgasmia.
A secondary anorgasmia, meaning they can't reach climax anymore.
Yes. It's the clinical term for the inability to achieve orgasm due to a secondary cause, which in this case is the physical barrier of the LS scarring.
That is heartbreaking.
It is. The psychological weight of losing that aspect of sexual function is incredibly heavy. But unfortunately, the physical complications of this fusion go far beyond just sensation loss.
Because it's trapped.
Right. You are taking a part of the body that is designed to be open and mobile, and you are sealing it shut. You're creating a closed compartment.
And a closed compartment in the human body is usually a recipe for disaster.
Almost always.
Because the body never stops producing its natural secretions, right? Under normal circumstances, the space under the clitoral hood accumulates smegma. And our sources are very clear to normalize this. Smegma is a perfectly healthy, normal mixture of dead skin cells and natural body oils.
Completely normal.
You wash, the hood retracts, and the smegma is just rinsed away.
But when you have clitoral phimosis, that natural rinsing process is physically impossible. You have an entrapment space.
Ugh.
The body continues to shed skin cells. It continues to produce oils, but they have absolutely nowhere to go.
Because the door is glued shut.
Exactly. So they build up beneath this sealed dome of scar tissue. And over time, that trapped smegma dehydrates. It hardens into these tiny, solid masses. The medical literature refers to these as keratin pearls.
Keratin pearls, which sounds very elegant until you consider the reality of having hardened masses trapped against the most nerve-dense area of the human body.
It's incredibly painful.
It honestly sounds analogous to getting a piece of grit or sand stuck under your eyelid. But in an area that swells with blood flow during arousal, I mean, the sheer pressure and friction of that has to be excruciating.
It permeates every single aspect of daily life. Sitting down, wearing denim, walking, all of it becomes a constant source of pain.
Wow, just wearing jeans.
Yeah. Furthermore, this trapped debris creates an environment that's just ripe for clitoral pseudocysts.
Pseudocysts, so like fluid buildup.
Yes, they're fluid-filled sacs that swell beneath the fused hood. And these cysts can easily become infected, occasionally turning into full-blown abscesses that demand emergency surgical drainage.
Oh my God.
And sadly, the complications don't even stop at the trapped debris. The scar tissue itself lacks any natural elasticity.
So when it's subjected to friction, like during sexual intercourse, it doesn't stretch.
Right.
It breaks.
It splits wide open. The sheer force on inflexible tissue causes painful tearing. This is a condition known clinically as vulvar granuloma fissuratum. The skin is essentially fracturing under the tension.
Fracturing. That is just, wow. And this brings us to what might be the most cruel paradox of lichen sclerosus that we found in the literature.
The scratching cycle.
Yes, because if you have that tearing pain, or if you are dealing with the agonizing deep itch of that initial inflammation we talked about, your natural, undeniable human instinct is to scratch or rub the area to find some kind of relief.
Of course it is.
But acting on that instinct actively feeds the disease.
It actually accelerates the destruction through a mechanism known as Koebnerization.
Koebnerization.
Yeah, named after the dermatologist Heinrich Koebner. The Koebner phenomenon occurs when physical trauma to the skin actually induces the formation of new disease lesions in that precise spot.
Okay, wait, so if you scratch it.
When a patient feels the intense itch of LS and scratches the skin, they create microtrauma. The immune system, which is already hyperactive and totally confused, responds to this new trauma by flooding the area with even more inflammatory cells.
So you're basically calling the robe contractors back to pour more concrete.
Precisely. The scratching triggers a fresh wave of inflammation, which creates a new plaque, lays down more rigid scar tissue, and ironically generates even more itching.
It's a vicious, self-perpetuating cycle.
It really is. Tearing from sex, rubbing from tight clothing, or scratching an itch literally drives the disease deeper into the tissue.
So you have a patient trapped in this relentless loop. Their anatomy is literally vanishing. Their nerve endings are blocked by keratin pearls and rigid scar tissue. And the very act of seeking relief accelerates the damage.
It's overwhelming for them.
It has to be. So how do you intervene? How do you break a cycle where even touching the area makes it worse?
Well, the intervention has to tackle the root cause before you can ever address the architectural damage. Lichen sclerosus is considered incurable, right? But it is highly manageable.
Okay, that's good news.
Yeah. The absolute first-line defense is putting out the fire of the immune response. We use ultra-high potency topical corticosteroids, the most common one being clobetasol propionate.
Okay, but how does rubbing a steroid cream on the surface stop those white blood cells from flooding the dermis way below?
It's because these ultra-high-potency steroids actually penetrate the epidermal barrier. They work on a cellular level to halt the transcription of inflammatory genes.
Oh, wow.
Yeah, they essentially signal the overactive immune cells to stand down, to stop releasing the cytokines that trigger the fibroblasts to produce that rigid collagen.
So it turns off the signal.
Exactly. By applying the steroid directly to the skin in a very specific regimen, we can halt the progression of the disease and prevent any further architectural distortion.
And what if the fusion is just beginning? Like, say the hood is just starting to tack down to the glands, but it hasn't completely sealed shut yet.
For mild fusion, the British Society for the Study of Vulval Disease guidelines suggest a manual technique.
Manual, like doing it themselves.
Well, guided by a physician, but yes. Patients are prescribed a topical lidocaine ointment, usually about 5%, to completely numb the area.
Okay, so they can't feel it.
Right. They are then instructed to gently, manually pull the skin apart to separate those early adhesions.
Okay.
Once the skin is physically separated, they apply the ultra-high-potency steroid directly into that newly open space. This suppresses the immune response in the raw tissue and prevents the hood from fusing back down.
Wow, okay. But let's look at the severe cases.
The fully encapsulated ones.
Yes, the patients who have suffered in silence for a decade. The house is completely concreted over, the clitoris is fully buried, and they are dealing with those trapped keratin pearls. I mean, a topical cream isn't going to dissolve a solid block of homogenized collagen, right?
No, it won't. At that stage of severe encapsulation, especially when it's accompanied by pain or dysfunction from pseudocysts, surgical intervention becomes necessary.
Surgery.
The objective is to physically unbury the clitoris and restore the structural anatomy. Surgeons utilize a few different techniques depending on how severe it is.
Like what?
Well, they might perform a lysis of adhesions, which involves meticulously cutting the scar tissue away to release the hood. They might utilize needle diathermy, using a highly localized heated needle to precisely melt and separate the fused tissues.
Okay.
Or, in cases where the hood is too severely damaged to salvage at all, they may perform a circumcision of the clitoral hood. They basically excise the scarred prepuce entirely so the glans remains permanently exposed.
Okay, I have to pause here and push back on this a little bit because the logic feels dangerously counterintuitive.
How so?
We just established that lichen sclerosus is triggered by trauma, right? Cognerization.
Right.
Taking a scalpel or a heated needle to an area packed with thousands of the most sensitive nerve endings in the human body is basically the ultimate form of physical trauma. Doesn't the surgery carry a massive risk of triggering an explosion of new scar tissue or permanently severing the very nerves we are trying to uncover?
It is a profoundly logical fear, and honestly, it's one that makes both patients and many gynecologists hesitant to pursue surgery.
It sounds incredibly risky.
It does. However, the data paints an incredibly reassuring picture. A pivotal study published in the Journal of Sexual Medicine by Flynn, Kraft, Goldstein, and their colleagues evaluated this exact concern.
Okay.
They conducted a retrospective review of women who underwent surgical correction for clitoral phimosis and labial adhesions caused by LS.
And the outcomes defied that cognerization risk we talked about.
The outcomes were overwhelmingly positive. Patient satisfaction was exceptionally high. We're talking 44% reporting they were very satisfied, another 40% satisfied. So that brings the total to 84%.
Wow, 84%.
Yes. But to address your specific concern about the nerve damage, there were absolutely no complications or worsened symptoms reported in the study. None of the women lost sensation as a result of the surgery.
Wait, really? None?
None.
But did the surgery actually succeed in restoring what the heavy winter gloves had muted?
Beyond just restoring it, the surgery actually revitalized it. Of the women who reported decreased clitoral sensation prior to the procedure, 75% reported increased clitoral sensitivity afterward.
That is incredible.
By removing the thick physical barrier of the scar tissue, the completely functional nerve endings underneath were finally able to receive direct stimulation again.
So they weren't dead, they were just blocked.
Exactly. Furthermore, the majority of the women who experienced severe pain during intercourse before the surgery reported either completely pain-free sex or vastly improved comfort.
That is staggering. The nerves were truly just lying dormant, waiting for the structural barrier to be removed. But, okay, how did the surgeons prevent the trauma of the scalpel from triggering a massive LS flare-up?
The key to that success is entirely dependent on medical management before and after the procedure. You cannot operate on active inflammation.
So you have to calm it down first.
Right. The underlying disease must be strictly controlled with those ultra-high-potency steroids for weeks or even months prior to the surgery. The immune system has to be completely quieted down.
Okay, that makes sense.
And then, post-surgery, the patients resume a strict steroid maintenance regimen to protect the healing tissue from a Kobner response. The surgery resets the architecture, and the steroids maintain the peace.
It is a remarkable convergence of medical strategy and surgical precision. I mean, we set out today to answer whether lichen sclerosus can cause the burying of the clitoris, and we've mapped out this intense journey from the initial immune malfunction to the pouring of the cellular concrete to the intense pain of a closed anatomical compartment.
It's a lot for a patient to go through.
It is. But the overriding theme of this deep dive is recovery. The clitoris is not destroyed, it is merely trapped. And through diligent medical management and surgical expertise, that space can be reclaimed and function can be fully restored.
The science and the surgical techniques are robust and they are highly effective. But, the most significant barrier to this recovery isn't biological.
What is it?
It's cultural. We're looking at a disease that could affect up to 1 in 80 women, yet it remains completely shrouded in silence. The deep-seated stigma surrounding vulvar health prevents individuals from seeking help. It resigns them to this false belief that their disappearing anatomy and vanishing sexual function are simply the inevitable consequences of getting older.
Which is why the clinical guidelines across all our sources strongly advocate for routine self-examination using a hand mirror.
Yes, highly recommended.
It is a profoundly simple act of knowing your own anatomical baseline. I mean, we wouldn't ignore our house slowly remodeling itself around us, right? So we shouldn't ignore the architecture of our own skin.
Absolutely.
So as we wrap up, I want to leave you with this final thought to explore on your own. Consider the massive gap between how common LS is and how rarely we hear about it. How much unnecessary physical and psychological suffering could be prevented if we simply normalize talking about and looking at our own bodies. Getting a mirror and taking a look is the first step in taking those heavy gloves off for good. Thank you for joining us on this deep dive.